You're listening to Medscape's In Discussion series on respiratory syncytial virus in adults, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Forrest Arnold. Dr. Arnold is the chief of the University of Louisville Division of Infectious Diseases and director of the Center of Excellence for Research in Infectious Diseases. He also acts as the co-editor-in-chief for the Journal of Respiratory Infections and program director for the Clinical Fellowship in Infectious Diseases. Relevant disclosures can be found with the episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, I'm Dr. Forrest Arnold, and welcome to Medscape's In Discussion series on RSV in adults. Today we'll be discussing RSV in the community setting with Dr. Brittanie West. Dr. West is a family medicine specialist practicing in West Virginia. Welcome to In Discussion.
Thank you for having me.
Dr. West, you are in Bridgeport, West Virginia, a relatively rural setting, and you went to the West Virginia School of Osteopathic Medicine, which the U.S. News and World Report ranks as #1 in graduates who go on to practice rural family care. Could you describe for us a typical adult patient you see who has RSV?
Absolutely. So I do live in Bridgeport, West Virginia. We have about 9,000 residents, so a very small town. This is kind of a conglomerate of my average patient. So I have an obese 67-year-old male patient. His past medical history, he has COPD, uncontrolled type 2 diabetes. His last A1C was about 9.5. He has CAD. He's had multiple stents in the past, 20 pack year smoking history as well. And he's presenting to our outpatient clinic a 2-day history of fever, productive cough, wheezing, and fatigue. He states his grandchild, whom he lives with, also recently had respiratory infection in last week. He's not sure whether or not the child was tested for RSV or not, or flu, or COVID. As far as the exam go, his vitals, he's a little tachycardic at 104. His respiratory rate 16, temps 99.6, but he has been medicating with Tylenol and NSAIDs as well. His pulse ox is 88% on room air, and his blood pressure is 150/90. On his exam, he has rhonchi and wheezing bilaterally. He also has decreased breath sounds overall, more so at the bilateral bases. He has regular heart sounds, no S3 or S4. He has no edema in the lower extremities and no JVD as well. The rest of his exam is largely non-focal. The initial differential of an acute respiratory complaint in this patient, an adult patient with comorbids, is really different than our pediatric counterparts. In the pediatric world, if it coughs like RSV, if it wheezes like RSV, it's RSV or flu or COVID. With our patient, just off his history components, he could have a COPD exacerbation, he could have pneumonia, he could have a viral illness, depending on what's circulating in the community, like RSV, flu, or COVID. So in our ambulatory setting, we're really lucky to have access to point-of-care ultrasound. So I can diagnose a little bit more before I send people for further studies. So for him, I would do a blue exam or a lung exam, pulmonary exam. And we know that POCUS is actually more reliable than our physical exam, particularly in diagnosing pneumonia. So what I would be looking for to rule in pneumonia would be B lines, or as I tell my residents, they are bad lines. They mean that there's fluid consolidation, particularly in a focal area. And we would also look for consolidations in that area, and that would help rule in pneumonia. And on the flip side, to rule it out, we'd be looking for the absence of that, which would mean that we don't have any fluid consolidation anywhere. And that would more suggest like a COPD exacerbation or viral illness like COVID, flu, or RSV. POCUS, particularly in a rural community, is essential. It helps to prevent delays of care, access to imaging or other testing modalities. But ultimately, our patient here would have to get diagnosed with a RT-PCR for flu, COVID, and RSV, plus minus maybe a CBC. If you have access to chest x-ray, that would be great. A CMP. And sometimes we do a procalcitonin if we really think they may be sick with a pneumonia, just to trend them out. And given his comorbidities, if all this was negative, we would probably consider an extended respiratory virus panel for him because he's at risk of getting pretty severe illness.
Okay. And the cause of pneumonia certainly could be RSV. He does have a broad differential. I'm sure RSV doesn't rise to the top, but it's definitely in the differential for somebody like you just described. So as you know, last year's RSV season was big news in large cities because that is where pediatric ICUs were filling up. What was it like for the rural physician?
I think first we have to dispel the myth that RSV is a pediatric disease. It is absolutely not a pediatric disease. Just like COVID or any other virus, it doesn't really see an age. It doesn't care if you're 8 months or 80 years old. It just wants to replicate and pass on its genetic material, right? It wants to survive. So each year in adults, we have about 60 to 160,000 hospitalizations. Last year, we were definitely on that 160,000 end that are hospitalized for RSV, and somewhere around 6,000 to 10,000 deaths. Compare that to pediatric population. They top out at about 80,000 hospitalizations a year and about 100, 300 deaths. And for perspective for our listeners, I work at a residency at an inpatient and outpatient basis. Our hospital is about 300 beds, but we have a tertiary care center about 40 minutes up the road. And we're the referral center for a lot of critical access hospitals and a lot of lower acuity hospitals. One of my feeders has like 25 beds. And I actually had our infection control team pull our RSV results over the past couple of seasons. So look at 2020 compared to 2022. And in 2020, our positive RSV swabs that presented through our multi-swab tanks, we had a flu, COVID, RSV tent, was about 245 positive for RSV. In 2022, we had 688 positives. And as far as the admissions go, I had them pull that as well. And our admissions are specifically for adults in this data set. We had 86 adult admissions last year compared to about 16 in 2020 during the October through December season. So that was still our peak. Ours didn't really shift like the urban areas did. And then we were also the overflow hospital for our pediatric tertiary care facility. And we are not used to taking care of kids on tiny BiPAPs. It was a lot for the hospital. And I think like most rural hospitals, when you have viral pandemics, whether it's flu or COVID or RSV, it really hits our nursing staff hard. Donning and doffing the PPE for that isolation status that they're under for respiratory, it eats a large chunk of their day, and they already are staffed at a higher acuity to have more patients per nurse anyways. That's really difficult.
Were you also the overflow for adult patients who might have gotten RSV? I'm sure you were for COVID.
Yeah, we retained a lot of our RSV admissions. Our tertiary care hospital stays pretty full, so we're almost always taking care of those. So that's probably real numbers for us. We also got a lot of transfers from the smaller hospitals for RSV care that they were worried may end up in an ICU setting or needed more intensive pulmonary consultation, those sorts of things.
And COVID, as we know, had a high incidence. How did that compare to the RSV that you saw last year?
We definitely had more RSV last year. During that October-December season, we admitted and diagnosed way more people with RSV. We had a couple co-infections in some of our really sick patients. We would have a flu and RSV or a COVID and RSV co-infection. And those were tough on those patients. They almost always got hospitalized. One of our residents actually got RSV as well. And they'd had COVID and RSV, and they said that RSV was way worse. We actually re-swabbed them a couple of times because we thought they were co-infected, but they were not. It was just RSV. In a rural community as well, the effect on the community is just so much more than an urban center. These patients can't afford to be off for the 8 days isolation that you have when you have RSV. So I think we all have to take that into consideration as well.
You mentioned swabbing, and that's available in the hospital, I'm sure. And what about as an outpatient? Is that also available?
So we're really fortunate at our hospital that we have access to a fourplex, the RT-PCR for RSV, flu A, flu B, and COVID, inpatient or outpatient. We have access to our extended respiratory panel as well, inpatient and outpatient. My feeder hospitals, some of them don't always have immediate access to RSV. They do have rapid antigens for flu and for COVID. But getting the fourplex is a little bit more difficult in some of our really rural communities that we feed from. And I think it's even more important now that we have antivirals for flu and COVID that we do test them for the fourplex. You know, my patients are pretty practical. They're like, Doc, if you're just giving me supportive care, I don't really care which one I have. And they don't want the medical bill for that fourplex. So if we can make a difference by giving them antivirals, then I think that makes a big difference.
Okay. What are some of the challenges you face as a primary care physician in a rural setting in particular?
Rural communities, particularly in Appalachia, where, we both practice, we have patients that have a lot of comorbid conditions. So if you think back to my case, that was my average patient. So they have COPD, they have CAD, they're older, they're immunocompromised from one thing or another, typically diabetes. And this places us at a higher burden than our urban counterparts. So for example, COPD is highest in Appalachian areas. It's actually, unfortunately, the highest in West Virginia. We have about 12% of our adult population that has COPD. Contrast that with Hawaii, who has the lowest rate. They're at 3%. So my patient here in West Virginia that has COPD would be at a lot higher risk than that patient that lives in Honolulu, Hawaii. We have a lot higher incidence of heart disease as well. We have about 382 deaths per 100,000 residents per year. So, that places us at a higher risk. And we're also older. So my state is one of the oldest states. We have 20% of our patients over the age of 65. And you compare that with other states like Utah, they have 11% of their state population over the age of 65. And it also doesn't take into consideration things that are hard to quantify. So as an anecdotal example, in my patient population, I have a lot of multi-generational households, either grandparents living with mom and dad or grandparents providing kinship care for grandchildren. So they get placed at high risk of exposure to all viral illnesses, including RSV. And they're already the patients that are at the highest risk. That's kind of an anecdotal thing that's hard to quantify in numbers, but it does create an issue in rural communities.
And what about vaccine hesitancy? Is that a factor that you have to deal with?
Vaccine hesitancy below the age of 65 in these communities is really difficult, but actually above the age of 65 nationally, if you look at the COVID-19 booster data, more than 40% of adults over 65 got the COVID-19 booster, compared to about 20% of the population between 18 and 65. So in my elderly adults, I think rural communities in that age bracket are more likely to want to protect the other people in their community and be able to help them out when they're in need. So I think that plays a role. But under 65, we have a bit of difficulty. And the COVID-19 vaccines also created a little bit of vaccine hesitancy. West Virginia as a whole doesn't have religious exemption for a lot of our school-age vaccines. So some patients are a little bit more accepting because of that of all vaccines because they were vaccinated when they were younger. But I think the best thing that we can do in rural communities is be a really good advocate for our patients. I'm an early career faculty going on my 5th year, but I work with docs that have had the same patient census for 30 years. And they trust their physician when they see Dr. Hess, who works in my office, and they've seen Dr. Hess for 30 years. And she says, I think you should get the RSV vaccine, or I think you should get the flu vaccine. They trust her. Or, they go to their local pharmacy. It's the same pharmacist they've seen for 15 years. And they say, your niece had RSV last year. We have a vaccine for that now. And they're picking up their Advair inhaler for their COPD, so we know our communities a little bit better. And I think we can advocate and kind of get them persuaded, but vaccine hesitancy is always still an issue.
My experience was that the older patients felt like they were at risk of getting severe infection if they got the infection, and the younger patients felt like they would just get over it. And so maybe that kind of fit with what you're saying. So it seems like there's risk factors that the adults have that makes their RSV worse, that they would have severe disease. How do you contrast that with the comorbidities that, say, a younger patient might have?
My state is in an interesting position in this. COPD, CAD, diabetes, obesity, smoking, all those things we know play a role. And unfortunately, in West Virginia and some other rural areas, we have a higher incidence of type 2 diabetes, obesity, even in our adolescent population. And one of the biggest issues and the biggest thing I'm worried about is vaping. So in West Virginia, the legal age to buy an e-cigarette or cigarettes is 18 years old. But they did a survey and about 36% of West Virginia high schoolers admit to regularly using e-cigarettes. When they surveyed middle schoolers, it was 17%, which is like 5 times more than the national average. And most of those teens, about 75% of them, said that their first exposure to tobacco products was an e-cigarette. And my worry is that they're going to have pre-existing lung injury in that 14 to 18 and then on to, that 20-year age group. And here in a few years, our ones that are vaping heavily now may have, vaping-induced lung injury and get more consequences of diseases like RSV and flu and COVID in their 20s and 30s. And we'll see COPD a little bit younger because of that.
Your role as a physician in rural America, how far do people travel to see you?
I am at a larger hospital. Like I said, I have a lot of feeder hospitals. So some of my patients travel an hour and a half to 2 hours on good days. That's without snow. And those are on back roads, not interstate, to come see us. I recently did sports physicals in Wetzel County, West Virginia, and their options to send patients are either to me, which is about an hour and 20 minutes away, or 45 minutes north to Wheeling, or 45 minutes down to Parkersburg. locally, they don't have a whole lot of access to care as far as needs when they're admitted to a hospital. Rural physicians in West Virginia are in an interesting position. Like I mentioned before, many people that practice in rural environments stay there. We try to get people retained in those communities. People that choose to stay in a rural environment realize that it's not just a job, it's really a lifestyle, and you're taking ownership of that community. So as far as things like RSV and flu and pandemics go, it's our job to take care of those communities. And actually, when I was a resident, I rotated in Big Sky, Montana at a ski resort. I wanted to see some trauma. I wanted to see ski injuries, and I thought that was cool in those days. And one of my first jobs when I got there was actually to do a flu vaccine clinic. I gave probably 200 flu shots to all these local dude ranches and resorts. I remember asking the physician why he was sending me to do that. And he said that a couple years before I did the rotation with him, that their entire community was brought down by a huge flu pandemic. And they have a 4-bed critical access ER. And then they had tertiary care facilities that they had to be either life flighted to or were hours away. He told me that it was his responsibility as a physician for that community to make sure that never happened again. The next year, he went to all the resorts and the dude ranches and everyone there and offered free vaccine clinics, and he got the state to help sponsor that. And the cool part was that the employers didn't have to require the vaccines of the employees like we sometimes do. I know our hospital does, but everyone had agreed to them because they wanted to help protect, their coworkers and protect community because it really, really affected them.
As you know, the Advisory Committee on Immunization Practices, what we know as the ACIP, recently met and recommended the new RSV vaccines for adults greater than 60 or 65 years, depending on the maker of the vaccine. How will that vaccine fit into your practice?
Yeah, we're really excited about this. As I mentioned, my patients have all the risk factors. They are the adults with chronic heart disease and chronic lung disease, and they have weakened immune systems. We have, physicians in our area that take care of patients in the long-term care facilities. And I encourage the listeners to go back and listen to the episodes on those as well to see how that, affects those environments. We know that the people that get hospitalized for RSV, 94% of them have some underlying medical condition. About half of them have at least 2 or 3. And that's my average patient. The Pfizer and GSK vaccines are wonderful, and they've been 50 years in the making. And I think patients will uptake them if their providers, the nurses, pharmacists, respiratory therapists they work with, make a really strong recommendation to do so. With GSK's vaccine, it reduced the risk of getting RSV by about 82, 83%, and severe disease by 94, 95%. So those are really great numbers. Pfizer's vaccine that doesn't have the adjuvant still had really good numbers. It reduced the risk of getting 2 or more symptoms by about 66% and 3 or more by 86%. So I think hearing those numbers and giving that data to patients and letting them choose is helpful. I also think we have to look at affordability. And recently, the Inflation Reduction Act got rid of copays for recommended vaccines under Medicare Part D, which is what a lot of these patients are going to be on that are getting the vaccines. The cash price, GSK said they're going to price their vaccine somewhere between $200 and $300. Pfizer said between $180 and $270. So for people that don't have Medicare, that might be a limiting factor. So I think, health systems need to look into how we're going to help with that and what funding we can get to be able to get that vaccine to those patients that may fall in between the cracks. But I think our practice's position on it is just to make really strong recommendations and sandwich them. We do similar thing with the HPV vaccine. When it has poor uptake, we say you're due for these vaccines in care today. You're due for your A1C or RSV vaccine, and we're going to order your mammogram today. And when you sandwich it in the middle, they tend to have a better uptake of that. And being open-minded that people are worried when there's new vaccines and new medical treatments that come out, and taking the time to talk with them about that.
The 2 vaccines you mentioned, companies Pfizer and GSK, are the 2 that are FDA approved at this time. And it's indicated for the elderly, but the other adults, 18 to 60, may be looking to see how they fit in. And what can you tell us about pregnant women and RSV vaccine?
They're looking at trying to passively immunize infants via their mothers. We do this already with pertussis. We give Tdap in the 2nd and 3rd trimesters to try to passively immunize infants. We also try to cocoon them, right? Everybody in their family gets the vaccine as well if they aren't up to date, so that we can prevent them from getting pertussis. A similar thought exists for Pfizer's vaccine. They're looking into the data of giving that to moms in that second and third trimester. The question then becomes, do you give them the vaccination or do you give the infants Beyfortus, which I think was in your last episode? I encourage listeners to listen about that. It is a huge advance over Synagis, and, it's a one and done administration of monoclonal antibody to all infants, not just the ones that are at risk for Synagis. And we know that a good chunk of babies that get hospitalized, about 75% of them are healthy babies. They're term babies that had no other issues. So I think moms have a good uptake of that and a good opinion of that. And they actually looked at, for moms, who would be willing to get the vaccine. University of Iowa ran in the CDC's value survey, surveyed either women that were currently pregnant or had given birth in the last 12 months. And they said that 68% knew what RSV was, so they had a baseline knowledge, which is important. And that 61% said they would consider getting the vaccine if their provider recommended that to them. So I think that is wonderful. And, the other patients may just need educated more, but it's a great opportunity. I think by the next round of these podcasts, we may know a little bit more about what they have decided, what the ACIP and the CDC have decided on that vaccine for pregnant women.
Today, we've had Dr. West discussing RSV in adults in the rural American setting. 3 messages pop out, and that is that RSV in adults is a known entity. Test for it and vaccinate for it. Dr. West, thank you so much for joining us. This is Dr. Forrest Arnold for In Discussion.
Thanks for listening to Medscape's In Discussion Respiratory Syncytial Virus in Adults podcast series with our host, Dr. Forrest Arnold. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out Medscape.com or the Medscape app for show notes, links, and more information on respiratory syncytial virus in adults.